All right, well, it looks like we have had a good number of folks start to sign on, so we're going to go ahead and get started with tonight's webinar. Good evening, everyone, and welcome. This evening, I am excited to bring you the next session in the Immune Deficiency Foundation's Decoding PI series. Tonight's featured topic is antibody deficiencies, led by Dr. Luke Wall from Children's Hospital of New Orleans. My name is Emma Martins, and I'm the Program Manager for Education at the Immune Deficiency Foundation. On behalf of IDF, we thank you for tuning in to this virtual event. Throughout this series, guest presenters will provide a deep dive into clinically advanced topics from the world of PI. If time permits, the session will be followed by an audience Q&A with our presenter. We hope through your participation in these programs that we may move forward in our mission to engage and empower the PI community through education. Here are a few items to keep in mind for the webinar. This evening, we are using the Zoom webinar feature, and attendees should be able to hear the presenter and host speak. If you wish to enable closed captioning, click Show Captions on your Zoom toolbar. You can view the full transcript by clicking on Show Captions and navigating to View Full Transcript. From there, the transcript will appear in real time on the right side of your screen. Attendees will not be able to activate their video camera or their microphone. That means all your questions will need to be typed in the Q&A box in the control panel of your screen. They will be read aloud on your behalf. Please refer to the ground rules for Q&A shared in the chat box. A recording of tonight's webinar will also be published on our YouTube channel. We appreciate your patience as it will take about 2 weeks for that upload to be completed. A brief disclaimer. Please remember that information presented during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning your medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. This webinar is made possible by our wonderful sponsors. It is due to their partnership and contributions that we can provide programs like this for the PI community. Please join me in thanking today's sponsors. And now I am so pleased to introduce our presenter for this evening, Dr. Luke Wall. Dr. Wall joins us from Children's Hospital New Orleans, where he specializes in pediatric allergy and immunology. He also serves as an associate professor of pediatrics at LSU Health New Orleans. Welcome, Dr. Wall, and thank you so much for joining us this evening.
Thank you, Emma, for inviting me. And I just want to commend the Immune Deficiency Foundation. I was just talking to Emma as I signed on a few moments ago. This is the first time in a little while that I've really explored through the IDF website in depth, and really the wealth of information that is available is really impressive. So I really commend your efforts and the foundation's efforts in making that sort of information available to patients. Let me go ahead and pull up my slides. And Emma, can you see the slides okay?
I can't see them just yet.
Okay, let's see.
Yep, those look good to me.
All right, perfect.
Thank you.
Okay, and so of course this evening we will be focusing on antibody deficiencies. These are my disclosures. I have participated in clinical trials for both Chiesi and Takeda, including subcutaneous immunoglobulin trials for Takeda, as well as advisory board for Chiesi. And I'm in an immunodeficiency work group for the nonprofit RareX, but that is not a paid effort, that is volunteer. So our objectives this evening are to review the well-defined antibody deficiencies. And at the end of the talk, certainly some of you will think, well, we haven't talked about my antibody deficiency because, of course, in real life, as you all know, there is a lot of variability, but really the only way to walk through this in an organized and sort of educational fashion is to really focus on the textbook defined antibody deficiencies. And for each of those, we will look at the age of onset, the immunologic characteristics, infections, other complications, treatment, and prognosis. We will also then highlight the role of advanced testing for certain antibody deficiencies and identify targeted treatments available for some molecular diagnoses. So starting with the very basics of antibodies. You will hear me refer to immunoglobulins and antibodies interchangeably. Of course, four main families of immunoglobulins, with IgG being the most prevalent in the blood. This is a picture of IgG, sort of a pitchfork sort of shape. These antigen binding sites, these are sort of the sticky ends. They are specific for one particular protein. And so therefore we must have millions of them that our immune system makes. The antigen binding site, of course, binding on to the bacteria or virus, hopefully a foreign antigen. And then here at the base, where the two heavy chains, this is called the FC region, and this region binds onto cells of the immune system to then lead to the immune processes. IgA, very much like IgG, but this is a dimer, so it looks like two IgG molecules sort of knit together. As you'll notice, it also encompasses a J chain and a secretory piece. And in fact, this is the immunoglobulin that is secreted the most at mucosal surfaces. So this plays an important role at the lining of the respiratory tract, the lining of the gut as well, for example, and helping to protect us against infections in those areas. IgM is the first antibody made with a new immune response, and it is, as you see, the largest. In fact, it is a pentamer. So it looks like 5 IgG molecules sort of knit together. As far as basic roles of antibodies, what we tend to think about the most or the way that they bind to bacteria. And so this can, in fact, neutralize bacteria or prevent it from sticking to human cells. Therefore sparing us from infection. Once an infection takes place, also antibodies help immune cells to recognize and engulf the bacteria. And they activate the complement system, sort of a different portion of the immune system. They both activate and work in concert with the complement system. So the complement system allows holes to be drilled directly into the cell surface of the bacteria, therefore directly killing the bacteria. Also, antibodies in concert with complement lead to highly enhanced removal of bacteria from the bloodstream and enhanced phagocytosis or eating of the bacteria by the immune cells. Some similar roles with viruses. We hope that antibodies often neutralize viruses, thereby preventing infections, but also forming larger clumps so that these tiny little viruses can actually therefore be recognized better by the immune system and engulfed. So the forms of antibody deficiencies that we will cover tonight: specific antibody deficiency, selective IgA deficiency, IgG subclass deficiency. I will give the disclaimer that IgG subclass deficiency is a little bit controversial, and so I actually don't cover it in as much of a formal fashion because it's difficult to find formal consensus on IgG subclass deficiency. However, I do think it's important to include hypogammaglobulinemia, specifically THI, or the transient hypogam of infancy, common variable immunodeficiency, and X-linked agammaglobulinemia, or XLA for short. So diving into specific antibody deficiency. So this is diagnosed in children 2 years of age or older. Many of these children, in fact, almost all of these children, will have symptoms of increased infection younger than age 2. We cannot make the diagnosis until age 2, however, because of the diagnostic criteria, which I'll cover in just a moment. It also can be diagnosed in adolescents and adults. So the immunologic characteristics are what we use to diagnose the condition. Low vaccine response to a pure polysaccharide vaccine. Traditionally, this is Pneumovax 23, and this is what we continue to use in our practice. And this is the reason why we can't make this diagnosis younger than age 2, because in normal physiologic processes, we do not expect the B cell compartment in a young child to be strong enough to respond in robust fashion to a pure polysaccharide vaccine until age 2. So therefore, we cannot say that there was failure of vaccine response until we can measure that at age 2. These patients have normal titers or normal antibody protection to protein vaccines, tetanus for example, as well as normal immunoglobulins. And the types of infections commonly affect the ears, sinuses, and lungs. As far as treatment, we treat the infections early and with prolonged course of antibiotics, sometimes 2 weeks, for example, as opposed to 1 week. Beyond this, the management is really based on the clinical severity. So if the patient is not getting sick very often, it is appropriate to watch and wait and monitor labs periodically, perhaps reassess with another Pneumovax in a year or so. Patients who are becoming ill frequently may benefit from prophylactic antibiotics. And if infections are very frequent or very severe, then they may benefit from immunoglobulin replacement therapy. For specific antibody deficiency, typically this would be implemented for at least 1 to 2 years. And then, especially in young children, we would then give them a trial off to see if their immune system had matured with age enough to do okay without immunoglobulin. As an aside, throughout this talk, I will abbreviate immunoglobulin replacement therapy, IGRT, and just keep in mind that this is sort of an overarching term that encompasses any form of IgG replacement. So traditional IVIG, subcutaneous immunoglobulin, or facilitated subcutaneous immunoglobulin. And because the IDF does have great resources on immunoglobulin replacement, I'm really not going to focus on that during this talk. So the prognosis for specific antibody deficiency is excellent, especially in children. Most of them will outgrow this disorder. They do warrant continued monitoring, at least annually, really throughout childhood. And as an immunologist, we have to keep in mind that when we detect a weak vaccine response, it is rare, but this could be the initial finding of a more severe immune defect. To highlight what I mean by that, here's a chart of numerous primary immunodeficiencies as well as secondary or acquired immunodeficiencies that are associated with impaired vaccine response. And this table is not all-encompassing. So there are many conditions. So we really must pause and think, does this patient have any other features in their clinical history, their physical exam, or their laboratory findings that might suggest a deeper immunodeficiency? Moving on to selective IgA deficiency. This is typically diagnosed in childhood or adulthood, and it's often silent, and these patients typically have a normal life. Immunologic characteristics are essentially absent IgA with normal IgG and IgM. Patients typically have normal vaccine titers, however, there are some exceptions to this. And there may be an association with IgG2 subclass deficiency. So this may be detected in some patients. Types of infections, those recurrent cytopulmonary infections, as well as intestinal infections, because IgA is so important along that mucosal lining. Patients are also more prone to autoimmunity. There is a correlation more specifically with celiac disease. No treatment is required for most patients. However, Antibiotics may be used for a longer course when infections occur. And for patients who are experiencing frequent infections, antibiotic prophylaxis may be beneficial. Prognosis is excellent, but it really depends on whether or not there's autoimmunity present and, of course, the severity of those autoimmune conditions. And those who have worsening pattern of infection need to be reevaluated because, again, it is rare, but this also could be the initial finding of a more deeply ingrained antibody deficiency. A little bit more about IgG subclasses. So the total serum IgG level is composed of 4 subclasses. They are denoted by IgG1 through IgG4. As you can see here on the screen, IgG1 accounts for the vast majority, up to 70% of the total IgG level, and then decreasing concentrations as we move to IgG4, which is only 1 to 3% of the total IgG level. IgG subclasses have overlapping function, yet there is a little bit of difference between the function of the various subclasses. For example, IgG1 and IgG3, or more specific for viral antigens or peptide antigens. And when I say antigen, I'm referring to, in this context, a foreign protein or a protein recognized by the immune system. IgG2 is more specific to encapsulated bacteria. So that means the common respiratory bacteria, such as Streptococcus and H. flu. And while I mentioned earlier that IgG subclass deficiency is a bit controversial, I can tell you that I have one patient who has completely absent IgG2 subclass and significant cytopulmonary infections, and she benefited drastically, is now essentially experiencing a normal life with immunoglobulin replacement. So these can be highly clinically relevant, especially if the individual subclass is absent or nearly absent. Part of the controversy comes in because of the fact that many individuals who fight infections in normal fashion may have low IgG subclass levels if they are measured. Therefore, we only make the diagnosis when the patient is truly demonstrating susceptibility to cytopulmonary infections and has a persistently low IgG subclass at more than one point in time. And some patients will, in fact, have more than one low subclass. And also the total IgG as well as IgA and IgM must be normal in order to make this diagnosis. So I mentioned to you that IgG1 comprises at least 60 up to 70% of the total serum IgG. Therefore, if IgG1 is low, then that often results in a low total IgG serum or blood level. That scenario is no longer labeled IgG1 subclass deficiency, but in fact is labeled hypogammaglobulinemia, or meaning low IgG level in the blood. So that diagnosis of hypogam carries much more weight. And in fact, oftentimes a patient may be diagnosed with hypogam when IgG subclasses have in fact never been tested. That is perfectly appropriate. And once the diagnosis of hypogam is made, there really is no reason to then check IgG subclasses because they are irrelevant in the context of low total serum IgG level. Moving on to a different manifestation of hypogammaglobulinemia, and that is transient hypogammaglobulinemia of infancy, or THI, which is much easier to say even for immunologists. And so this is diagnosed in infants and toddlers, but they must be over 6 months of age because that's the point in which the maternal IgG in the blood has waned. And so then when we measure IgG, we know that we are measuring, in fact, the infant's IgG. Immunologic characteristics, not only the low IgG, but many patients will also have low IgA or M. but the immunoglobulins are present to some degree. They also have normal vaccine titers. Types of infections are those common sinopulmonary infections. Other infections are possible, but any severe infection in this context is really very rare. Allergy is common amongst these children. And treatment involves just addressing infections early and aggressively, once again, with perhaps a more prolonged course of antibiotics, monitoring with periodic lab evaluation. Some of these patients may need prophylactic antibiotics, and if they're really getting sick a lot, or if they're having recurrent pneumonia, for example, then most immunologists, myself included, for those patients who are manifesting severe clinical symptoms, will initiate immunoglobulin replacement therapy. Prognosis is excellent because it resolves over 2 to 5 years of age. But these patients warrant continued monitoring into adulthood just because surprises can sometimes arise in the future in these patients. All of this being said, transient hypogam, to know that it's transient, it's only a retrospective diagnosis. So we can only firmly make this diagnosis when the patient is age 5 or so, has outgrown this, and we're really looking back saying, okay, things look great now because you've outgrown this. We know that this was THI. During the heat of it, while we're detecting the hypogam and we're deciding how to treat and such, we generally just call it by the general term hypogam, and we have to keep in mind that there could be a more deeply ingrained antibody deficiency, and we have to keep our eyes open for that. Now, focusing in on a very severe antibody deficiency, X-linked agammaglobulinemia, agammaglobulinemia meaning that no antibodies are produced. So the reason that we call this X-linked is because, in fact, the inheritance is X-linked recessive. So it is on the gene is on the X chromosome, meaning that it not only can be passed to the next generation, but it means also that females who have the gene mutation are a silent carrier, because as you can see in the diagram, females have 2 X chromosomes. So if there's a mutation in one, then there still is a healthy copy. For males, if they have the mutation, then they manifest the disease. And this is because males, of course, have only one copy of the X chromosome. They do not have another copy to compensate. So this, again, is diagnosed age 6 months or older. Immunologic characteristics, by the way, unless there's a family history. If there's a known family history, strong family history, then genetic testing, of course, can detect this less than age 6 months. Immunologic characteristics, absent B cells as well as absent immunoglobulins. Types of infections, bacterial, sinopulmonary infections, skin and soft tissue infections, and then they also may be prone to viral infections such as enteroviral meningitis. By the way, many other genetic defects now are known to cause agammaglobulinemia, most of them from an autosomal recessive fashion. So it can also be seen in women due to other genetic defects. These patients are also prone to other complications such as neutropenia and autoimmunity. Treatment absolutely must include immunoglobulin replacement therapy. This is life-sustaining. If infections continue despite immunoglobulin, then consider prophylactic antibiotics and, of course, treating those infections aggressively. This is a lifelong disorder. However, patients tend to do very, very well and have essentially a normal life with the immunoglobulin replacement. Moving on to common variable immune deficiency. So this is classically diagnosed in adolescence or adulthood. It can be diagnosed in younger children, especially if a genetic defect happens to be found. Speaking of that, it's always generally always been said that CVID is sort of a basket, right? A basket of various phenotypes, hence the word variable in the name. When I say phenotype, I mean the manifestation, right, of the underlying disease. So lots of variability here. We've also always thought that there probably are multiple genetic mutations, genetic defects. Also, in more recent years, we think also that there could be epigenetic factors, things that sort of stress or alter the gene functions that lead to CVID. And of course, many patients still have, we can't detect a gene. We don't know the reason that they have CVID. I'm saying that because really, most technically, once we, and for patients who do have a well-defined genetic defect leading to that CVID phenotype, in that scenario, really then they should be called by that genetic defect. And it's appropriate to say as a description with a CVID phenotype. But most immunologists will agree that at that point in time, they really come out of that CVID pool and they're looked at through a little bit of a different lens with that specific molecular diagnosis. And it can be important to make that diagnosis, and we'll focus in on that a little bit more on some future slides. So we make the diagnosis for CVID with a low IgG as well as low IgA or M or both, and low vaccine titers without any other explanation as far as a secondary immunodeficiency, medications, and such that can be weakening the immune system. Once again, those recurrent cytopulmonary infections. Mycoplasma can be more of a challenge in patients with CVID. This is the common bacteria causing walking pneumonia. Intestinal infections, Giardia, as well as viral intestinal infections can really be a challenge. And joint infections and unusual infections can also occur with unusual organisms for that site of infection, such as Mycoplasma, for example. Autoimmunity is relatively common, including cytopenias or low blood cell counts, as well as multiple types of organ involvement. Treatment essentially always involves immunoglobulin replacement therapy, as well as aggressive treatment of infections, treatment of underlying autoimmunity. If autoimmunity is present, oftentimes rheumatology is also on board, as well as a specialist for whatever organ is involved. Continued monitoring for that organ involvement or potential future organ involvement. We want to detect that early on if at all possible. And of course, screening for malignancy. Prognosis is generally good and with a good quality of life if diagnosed early and treated aggressively. Factors that really affect this. So, is there organ damage at the time of diagnosis? If so, how severe and which organs? Bronchiectasis, for example, can really be a challenge moving forward. Also, that autoimmunity or granulomatous inflammation resulting from autoimmunity or immune dysregulation as sort of a more general term. This, of course, is going to often require various immune modulators, and patients can suffer from the comorbidities related to the underlying inflammation as well as side effects from the medications. So there has been a shift in the tide. There is decreased mortality from infections. We've become actually pretty good so even if we have to use higher doses of immunoglobulin, we've become very good at reducing severe infections in CVID. So there really is increased longevity in patients, but increased non-infectious complications. Some of that is because patients are living longer. Just to highlight some of the manifestations of CVID. So this is from a paper from over 10 years ago, but it did a really great job at highlighting many of these things. So of course, infections in the vast majority of patients with 30% or so experiencing autoimmunity and cytopenias, 30% with chronic lung disease, inflammatory bowel disease, and at least 15%, and then on down the list. So many challenges that these patients may face. So more aggressive monitoring and treatment is warranted in some scenarios, using a few, for example, with bronchiectasis. we as immunologists will often really crank up the immunoglobulin replacement because we want to do our absolute best to reduce future lung infections and try to reduce that inflammation in the lungs from foreign pathogens. Measuring memory B cells can really be insightful because even if a patient does not yet have manifestations of autoimmunity, if they have exceedingly low class switch memory B cells, they are at increased risk for developing autoimmune complications. The granulomatous disease, especially if severe liver and spleen enlargement, and sometimes you'll see severe lung involvement with the granulomatous lymphocytic interstitial lung disease. This can, of course, require much more aggressive treatment. And then other organ dysfunction, again, with the treatment specified for the organ that is involved. So just to recap on the antibody deficiencies that we have discussed before we talk a little bit more about some detailed testing and treatment. So specific antibody deficiency, the key point for that, identifying that or separating it from the other antibody deficiencies is that weak polysaccharide vaccine response only, right, with your normal immunoglobulins. Selective IgA deficiency, essentially absent IgA as the only immunologic finding. This condition is the one that is not treated with immunoglobulin replacement therapy. We cannot replace IgA. IgG subclass deficiency is that low IgG subclass only with normal total IgG. Other immunoglobulins are also normal. And again, there is some controversy, but there certainly can be clinical importance to this condition, especially if the subclass is very low and the patient is getting sick frequently. Transient hypogam of infancy, low immunoglobulins only. So the vaccine response has to be intact in order to make this diagnosis. These are young children, and the true diagnosis is only made retrospectively. CVID, older child or adult, low IgG plus at least one other low immunoglobulin. Weak vaccine response and autoimmunity is common and possibly severe. And XLA, typically diagnosed in infants or young toddlers, hopefully diagnosed very early in life, with absent immunoglobulins and absent B cells. So as we transition into specific treatment, I wanted to introduce this by highlighting some CVID lookalikes. This is going to be sort of rapid fire. We're going to move quickly, and we're going to talk about a lot of the cell surface receptors, intracellular signaling, and such. Each one of these conditions can be an entire lecture in and of itself. So this really will be a quick overview. What I want you to take home is that it does make a difference in these conditions that the specific genetic defect was identified. And it makes a difference because there is a specific treatment available. So the first one I wanted to highlight is CTLA-4 deficiency, which I found recently in a patient. LRBA deficiency manifest almost exactly the same, and I'll illustrate to you why that is. And so this often presents with a CVID sort of phenotype with severe autoimmunity. In this patient example, there was a refractory thrombocytopenia, so profoundly low platelets to a dangerous level that really did not respond well at all to treatment. Enlarged liver and spleen with severe interstitial lung disease, and this in fact was a child. Genetic testing revealed CTLA-4 mutation. So therefore, we were able to treat this child with abatacept, and abatacept is a CTLA-4 fusion protein. So it, in essence, is a laboratory-made antibody fused with CTLA-4, allowing us to give that molecule in the form of an infusion. So thereby treating this defect exactly at the molecular level. Here in the cartoon, what you're seeing is an antigen-presenting cell at the top with that cell wall. At the bottom, you see a T cell with its cell wall, and the sort of light color or whitish area in the middle is the area between the two cells where this synapse is taking place. Over on the right-hand side, we have the normal way that these antigen-presenting cells will present that foreign protein to the T cell receptor. This is a primary signal, but it requires a secondary signal. And in this example, we have this cell surface molecule CD80 or CD86, which when we are forming an immune response, CD8086 binds with CD28. After a brief period of time, perhaps hours to a day or so of this immune response really cranking up, then CTLA4 steps in and it actually bumps CD28 out of the way. CTLA4 then steps up to the plate, binds CD8086, and it actually begins to dampen or inhibit the T cell response. Why? Why would we want to do that? Well, we do not want our T cells to continue to respond unchecked for every immune response that we have. That leads to unchecked inflammation, leading to autoimmunity, which we see in CTLA4 deficiency. So this is a beautiful way in which we can exogenously or through an IV administer CTLA4 to treat this condition. Here inside the T cell, we see LRBA at work. What LRBA does is that it helps to sort of make sure that CTLA4 gets to the cell surface, make sure that it's recycled appropriately as opposed to being broken down too much by the lysosomes. So it sort of helps to regulate and make sure that CTLA4 is expressed appropriately. And that's why LRBA deficiency is manifested almost exactly like or clinically identically to CTLA4 deficiency. And it is also amenable to treatment with abatacept. Moving on to APDS, or activated PI3K delta syndrome. This condition has gained a lot of buzz in recent years, especially since we now have a treatment available. The gene nomenclature and the protein nomenclature are slightly different. Okay, so those are not typos, but that's neither here nor there. But this is due to a PIK3CD gain of function. So the mutation, as opposed to causing the gene function to break, it actually causes increased function and increased function of the protein that is expressed. And it can also be due to a mutation in a molecule with a similar role, PIK3R1. And you see a little cartoon here. The brown area is inside of the cell with the light sort of off-white color being outside of the cell. You can see this green box representing cell surface or cytokine receptor, the little red triangle being the ligand, right? Or the cytokine which is bound to the receptor, activating the receptor. And we can see that PI3K plays an important role here with transmitting the response from the receptor to the inside of the cell. Cascading down to making sure that the nucleus functions appropriately and the gene expression is increased in response to this cell surface receptor. So you can picture that if PI3K continues to crank, right, continues to work unchecked, that it's going to lead to too much activation of this cell. So this condition has autosomal dominant inheritance. It does present a CVID immunologic phenotype. However, it also is considered a combined immunodeficiency, meaning that it impacts T cell function as well. So they not only get those bacterial cynopulmonary infections, but also chronic viral infections with EBV, the virus that commonly causes mononucleosis, as well as a similar virus, CMV. Lots of autoimmunity and lymphoproliferation. Really, these patients can suffer very severely from that, with an increased risk for lymphoma, especially EBV-related B-cell lymphoma. So because this is an overactivity of PI3K, it leads to downstream hyperactivation of mammalian target of rapamycin, or mTOR. This is a protein inside the cell that it really is responsible for many cell functions, including cell proliferation and such. So it really drives forward cell activation and cell function. Therefore, we can treat this with rapamycin, also known as sirolimus, which inhibits mTOR. For patients who are currently, the indication is age 12 and over. There is now a commercially available drug, which is a PI3K delta inhibitor. The generic name for that is leniolisib. Joenja, or Joenga, however you choose to pronounce that, is the currently, to my knowledge, the only brand name that this is under. But really a beautiful way, again, to treat this at the molecular level. One other specific defect that I wanted to highlight is STAT3 gain of function. So once again, an overactivation of the gene based on a mutation. This one also is autosomal dominant, presents very much like CVID, so hypogam, also with low class switch memory B cells. But there is also a combined immunodeficiency component. Lots of autoimmunity. These patients might also demonstrate poor growth or short stature. Here's a cartoon just showing the cytokine receptor. In the situation of STAT3, it's predominantly IL-6, which is the cytokine which binds to the receptor, driving JAK-STAT activation, STAT phosphorylation, and then STAT3 then leading to activation and transcription in the nucleus. Transcription meaning activation of genes producing increased gene function and protein expression. So once again, you can picture that if STAT3 is continuing to crank, continuing to work overtime, even when everyone else is trying to quit, it drives forward a tremendous amount of cell activation and inflammation. So treatment options include tocilizumab, which is an anti-IL-6, so we can block that cytokine from binding to the receptor, thereby dampening the IL-6 JAK STAT3 pathway. This can be very helpful for autoimmunity. JAK inhibitors can also be helpful. One downside of the JAK inhibitors is that it is sort of like using more of a shotgun approach or casting a larger net, dampening multiple JAK-STAT signaling pathways. So sort of a larger reach and perhaps leading to, well, really, it does lead to increased risk for infections. There are also other STAT gains of function, STAT1 gain of function, for example, also gaining a lot of attention within the past couple of years. And these are all amenable to treatments along the same sort of theory. Now, talking a little bit more about advanced testing. So all of the conditions that I just highlighted for you are based on a specific genetic finding. So what about genetic testing? When is it warranted? Well, genetic testing is not required for the diagnosis and management generally of antibody deficiencies. However, I will say if the laboratory findings, the immunologic evaluation is really pointing toward or fits with agammaglobulinemia, so essentially absent B cells, profoundly low immunoglobulins, it certainly warrants testing because we want to know also which gene it is. We want to be able to counsel on reproductive risk. If this is a child, also counsel the parents on their reproductive risk for future children. Those patients with CVID and other antibody deficiencies that really have infection-only phenotype, then genetic testing is not highly likely to really reveal an underlying molecular diagnosis leading to advanced therapies. However, in patients who experience immune dysregulation, autoimmunity, malignancy, or other organ involvement, other complications, then it certainly is worthwhile considering genetic testing. As far as functional testing, so this really has grown a lot in recent years. When I say functional testing, I mean measuring the actual protein product that we're thinking about, or actually measuring how well a cell functions along the same line. For instance, stat phosphorylation. It can be measured in a functional manner. This can be highly valuable in resolving genetic findings that are listed as a variant of uncertain significance, as opposed to a true pathogenic variant on a genetic testing report. So when there is a VUS, a variant of uncertain significance, that means it's undetermined whether the variant is really impacting gene function or not. If there is a functional test available for that particular gene, that's the ideal time in which to implement that test. Again, availability is limited, but it does include the CVID-like conditions that we talked about. So APDS, some degree of functional testing is available. To my knowledge, right now, the only way to really gain access to that is through the pharmaceutical company Pharming. I do believe that it's on a research basis and requires a consent from the patient, which I believe is obtained directly through Pharming. But also, this could be available in research labs in various places, especially at immunodeficiency centers. LRBA protein expression is available commercially at Mayo as well as Medical College of Wisconsin. And the stat gain of function studies are available, or stat phosphorylation study is available at the Medical College of Wisconsin. So in summary, antibody deficiencies are widely variable. Some require aggressive treatment. There is an association with autoimmunity for many of these. All should be monitored over the course of time. Consider genetic testing, especially if the patient has more than the infection-only phenotype. And the majority of patients with modern treatments do have a good life. I wanted to highlight a few helpful resources. Many of you probably, or most of you are probably already aware of the resources available through IDF. If not, please explore their website. And specifically the Patient and Family Handbook. When I make new diagnoses for patients, I often print the chapter and hand it to them as I'm explaining the condition to them so they will have additional resource in hand. So it really is an excellent tool. Immunodeficiency search is really geared more for clinicians. However, it is a nice way to sort of in a concise fashion be able to compare various types of immunodeficiencies as well as look at sort of a category of immunodeficiency and see which ones are listed under that category and such. So it may be of interest to some of you. And then Medscape, which I believe is public access, has nice summaries on many of the antibody deficiencies. So with that, I really thank you for attending today. Thank you for the opportunity to speak. And I will turn it back over to Emma, and we'll be happy to entertain some questions.
Wonderful. Thank you so much, Dr. Wall. All right, give me one moment. All right, thank you so much. We have some great questions lined up. I know our audience is really excited for Q&A, so looking forward to getting this started. All right, so we're going to start off with a couple of questions about specific antibody. This individual says, hello, and thank you for a great presentation. So, is specific antibody limited to children, or do adults also get diagnosed with it? And they apologize. Sorry if I missed this earlier in the talk.
So that really is an excellent question, and specific antibody deficiency should be explored in adults who are having recurrent infections. Absolutely, it can be diagnosed in adulthood. Again, we have to always think, could there be another underlying immune deficiency? And in adults, I really pause and think, is there any secondary immune deficiency? Are they um, uh, for example, is there a medication, but another biologic for other reasons, or something else that is suppressing the immune system? But absolutely, it can be diagnosed in adulthood.
Thank you so much. And building on that question, another attendee asks us, for adults who have been initially diagnosed with specific antibody deficiency and placed on Ig replacement therapy, can you clarify how they know whether their disease has progressed to CVID?
Okay, so that's a very insightful question. And so there are some ways in which the antibody compartment can be monitored even while on immunoglobulin replacement, but of course it is limited. It's limited because while on replacement, you cannot measure specific antibodies because you're only measuring the antibodies from the donor, right, that now are measurable in your blood. You also cannot measure the patient's intrinsic IgG level because the IgG level that you measure, of course, is your IgG combined with the IgG that's been given to you. So those two measures are sort of out the window when it comes to reassessing. However, the immunologist can monitor IgA and IgM. If one or both of those becomes low, then there is suspicion for progression of the antibody deficiency. The only way to really make that diagnosis of did it really become CVID or not is really to come off of the infusions for 6 months and then reassess. However, speaking personally, and every immunologist, their approach is a little bit different. If I have a patient on infusions and I'm seeing measures such as the IgA or IgM that are becoming lower, then I'm not going to take that patient off of infusions because I have evidence that the antibody deficiency is becoming worse. So in that scenario, the only reason that I would pause and reassess is, for example, if the insurance completely refused to pay and we're really forced to come off of infusions for a period of time, or for some other extraneous circumstance that the patient could not infuse for a period of time. Um, but I really feel that if there is evidence of progression, when I say progression, I mean worsening, then infusions should continue as opposed to being paused for formal reassessment. I hope that helps to answer your question.
Thank you. All right. So moving on to some more questions about CVID. This individual wants to ask a clarifying question, and they would like to know, does CVID necessarily include IgG deficiency plus IgA or IgM, or is IgG deficiency on its own significant enough for a CVID diagnosis?
Okay, so consensus definition for CVID. In other words, the details that immunologists across the board really agree on is that it must include low IgG plus at least one other immunoglobulin. So plus IgA and or IgM. Okay, so IgG plus at least one of the others, as well as failure of the polysaccharide response using Pneumovax 23 as the traditional way of measuring that. So really, that is the only way to diagnose CVID. If a patient has low IgG alone, then they have hypogammaglobulinemia. That is the most appropriate diagnosis for them. That the implications of that are very general. And I say that because patients can have hypogam due to an intrinsic weakness of their immune system. So the immune system is just not able to make IgG. They can have hypogam due to loss of antibody. For example, if they're losing protein in the gut or in the urine, two of the most common examples, IgG is going to be the most the immunoglobulin that is lost the most. So it's going to manifest with IgG deficiency before any other antibody drops. Also, it's relatively common for hypogam or low IgG to be due to secondary immunodeficiency or immune suppression. So medications, for example, in anti-epileptic drugs, any medication that is used for immune suppression for autoimmune or any inflammatory condition, those can often lower the IgG level. So when it is IgG alone, we as the immunologists really have to sit back and take a hard look to see is there any explanation that we can find for it. If not, then if the low IgG is severe, and the patient is getting sick significantly, then that alone can warrant immunoglobulin replacement therapy. So hypogam in isolation can warrant immunoglobulin replacement. I will say, especially for pediatrics, most patients that I identify with low IgG alone, most of them don't get immunoglobulin because for kids, oftentimes it's transient. Oftentimes their symptoms are not severe. But there are patients, especially a couple of adolescents or adults, that I have started on immunoglobulin replacement for IgG alone. So it really comes down to clinical decision making. How severe is the patient suffering, and can we identify any underlying secondary immunodeficiency or reason for loss of antibodies?
Thank you so much. All right, next question. How do you know if your antibody deficiency, such as CVID, is mild, moderate, or severe? Is there criteria for these levels?
Okay. Um, so to my knowledge, there is not when it comes to CVID, and I would venture to say even if it is out there, it's probably one expert or one center saying one thing, and then other experts having other opinions of how to define that because that is very subjective. That being said, I'm glad that you brought that point up because I really tend to look at that more through a clinical lens. Okay, so mild being not having any autoimmunity, patients having a good life, they're not suffering drastically from infections. We've started IVIG because we've diagnosed the CVID. We've started IVIG and they're really doing wonderfully. They have no end organ damage, okay? Whereas severe would be, in my mind, and again, this is very subjective, it's very clinical, this is just the way that I see things. Your immunologist may describe things somewhat differently, but in my mind, the patients that really get my attention as far as very close follow-up aggressive treatment using the immunoglobulin to aggressively and such, um, or those that have organ involvement, for example, bronchiectasis and or interstitial lung disease, as well as other manifestations of autoimmunity. And for that small percentage of patients that really continue to struggle with infections despite immunoglobulin replacement. And so we really have to crank up the immunoglobulin dose because we really have a difficult time controlling their infections. So to sum that up, it's very subjective, but that's sort of how I see it through my clinical lens.
Thank you. That was a great answer. And speaking of which, the next is just a nice comment that I wanted to share, just so you have an idea of how much our patient community appreciates your talk tonight. This individual just wanted to share the way you explained everything was so straightforward, and I really appreciate that I was able to follow along and understand through the duration of your webinar. Thank you so much. So thank you for that nice comment, and thank you, Dr. Wall.
Well, that's a wonderful compliment. So thank you for sharing that.
Yes. All right, next question. So this individual says, I know you can't speak to my specific situation, but I had a traumatic splenectomy as a young person. Do you know if there's a correlation between something like that and the development of CVID? Could it have been brought on by the splenectomy?
Hmm. So, I've never encountered that specific question. So, I would say no, okay, as the most straightforward answer. But some of my thoughts on that. So, from the way that you phrased the question, I'm sure that you've done some, some of your own reading and have some knowledge base along these lines. But of course, the spleen is important for vaccine response, especially that polysaccharide vaccine response. So not having a spleen can, yes, make you more likely to have a failure of that measured vaccine response. Okay, so that part of CVID, yes, all right, not having the spleen certainly contributes to that. However, the spleen does not really play any direct role as far as forming the immunoglobulins, at least not to a substantial degree. Um, and so I really don't think that there would be any direct correlation between a previous splenectomy and development of CVID.
Thank you, Dr. Wall. All right, the next couple of questions are going to be about vaccines. So, first question, since some of us do not respond to polysaccharide vaccines, are there vaccines that we should not bother getting?
Hmm. So, um, trying to think which ones are predominantly polysaccharide that are commonly used. So, at least one version of the meningococcal vaccine, I believe, is predominantly polysaccharide. Outside of that, I believe most of the other ones, at least here in the United States, are protein conjugated or live vaccines. Salmonella vaccine is a polysaccharide vaccine, and in fact, that is used in some centers to measure um, the polysaccharide response. So, all of that being said, generally, even if a patient does not respond well, I still encourage all of the vaccines. However, I may also encourage in some situations additional vaccination. For example, if a patient has demonstrated that they do not respond to the pneumococcal polysaccharide vaccine, then considering the newer version of the Prevnar 20. So it's, conjugated vaccine. So it has that protein component and covers for 20 serotypes now. So that could be considered for sure. All of that being said, this would apply to patients who are not on immunoglobulin replacement. For those who are on immunoglobulin replacement, really you're getting the antibodies passively from the donors. So at least in our center, we generally do not immunize while on the immunoglobulin replacement. Apart from the seasonal influenza vaccine, we do recommend it, but that's really the only one.
Thank you. All right, next vaccine question. For folks with CVID, is there a general schedule of vaccines that you would recommend?
Yeah, so I think I began to touch on that with the point that I just made. So If you have CVID, I would assume you're on immunoglobulin replacement, and therefore really only the seasonal influenza vaccine. Also, now that we are that sort of, I don't know, what do you call this, post-COVID era? COVID era? I don't know. COVID has just become a part of our normal lives. It can also be beneficial to receive the COVID vaccine as well as the COVID boosters. Um, but really, those are the only two. And the reason that most immunologists, I do believe, would still encourage those two vaccines, even though we're not encouraging others. The reason for that is that in the general donor pool that's donating the immunoglobulin that you are receiving, we assume that most of those patients have previously been immunized for, all of the other things, pneumococcus, tetanus, on down the list. So you are receiving those antibodies passively. The reason that we view influenza differently, and now even COVID differently, is just because there is so much drift or genetic change in those viruses from one month to the next or one season to the next. And the product that you're receiving in the immunoglobulin may have been collected 9 months ago, or perhaps even longer. And so the immunoglobulin that you're receiving today, at least in theory, is not going to contain good, strong antibodies for the current strain of COVID that is circulating or the current strain of influenza that's circulating. Now, it will have some of the antibodies against previous versions or some of the antibodies against some of the more fixed antigens, right? Or the antigens that don't change as much, perhaps, on those viruses. But as far as those neutralizing antibodies against those the important viral proteins, the immunoglobulin you're receiving right now, it may be weak in that for this season's influenza and this season's COVID. And most patients, even with an antibody deficiency, even on immunoglobulin, would at least have some degree of response to influenza vaccine, COVID vaccine, even though it may be a weak response, at least gaining some T cell training or T cell memory for those vaccines. So it really would be those two while deferring really any of the other vaccines while you're on infusions.
Thank you. And last vaccine question, at least for a moment, because I know
Mhm.
that there's more coming up down the line. Will people who start receiving IG treatment therapy start to have a normal vaccine response?
Possibly. In children, we commonly use the term outgrow. And so their immune system may strengthen over a period of time. Personally, I do not think that the IVIG, the immunoglobulin replacement, is really having anything to do with that. You can find um, uh, experts who feel differently, and you can find some very limited studies that, may show or give some suggestion that the immunoglobulin may be altering the immune system in a way that affects the vaccine response or the specific antigen response. I don't think that it really affects it in any clinical way. It supports you by giving you those antibodies that you need while you're on the infusion, and then time, right? Time can be our friend. The immune system can strengthen over the course of time, especially in children and adolescents. That's why often after a couple of years in our young patients, we may then pull them off of the infusions to reassess, see if they're strong enough. Sometimes, however, time goes against us, and we certainly see some patients, a handful of patients, in which the immune system tends to unravel or worsen over the course of time. And that's one reason why I really emphasize that some patients, such as are what seems to be not the most severe antibody deficiencies, even the THI, even when it seems that they've improved, it still warrants annual monitoring because we really never know what's going to happen to the immune system moving forward. So, bottom line, the ability to form that good vaccine response may develop. It may develop even while you're on infusions. I don't think it's related to the infusions. I think it's related to time. And the only way to assess that is to come off of the infusions after a couple of years and reassess.
Thank you. All right, next question. Do you have any information on how systemic inflammation is treated in CVID patients?
Sure. So, there are eh, there's a myriad of ways to do that. A lot of it depends on where the inflammation is. I am not a rheumatologist. I do not have expertise in autoimmunity or autoinflammation. So I oftentimes will bring in the rheumatology experts and really let them lead the way with that. If there's a specific organ involvement, then I will bring in the expert surrounding that specific organ and then just sort of assist them with ongoing monitoring and such moving forward. But there are a number of ways that that could be done. Some patients or just some immunologists may even, especially for very severe patients, use rituximab, which actually wipes out the B cells with the theory that, okay, the B cells are not making good antibodies. They're not sustaining the immune system in a healthy way like we would want antibodies to do, or like we would want B cells to do. And in this scenario, the B cells, in fact, are only making autoantibodies. And so, you may use rituximab, which is an B cell antibody to wipe out the B cells, at least for a period of time, and then just continue supporting with immunoglobulin. And then from there, there are many different medications that can be used to address that inflammation. The beautiful thing is that when there is immune dysregulation or autoimmunity, and we can identify that genetic defect, then oftentimes at least in the three scenarios that I described, we can treat right at the molecular defect. And that generally is greatly helpful and reducing the inflammation.
Thank you so much. All right, next question. Do you recommend any particular centers that would be doing CVID research? This individual shares, we have 4 people in our family with CVID, and all genetic research has come back inconclusive. But they say that they have just not located the exact genetic pieces that can connect the dots for us just yet.
Sure. So thanks for your question. Certainly, it's in the setting of CVID, especially if there's not severe immune dysregulation, it's not surprising to an immunologist if the testing comes back completely normal. Um, that being said, with having 4 individuals in your family, certainly that suggests, right, that strongly, of course, suggests that there is a genetic link there that has not been found. One thing that you could look to is to request whole exome sequencing if that has not yet been done. And then really, I would encourage you to have a talk with your immunologist as far as who they would suggest as far as a research center. There are a few across the US. I can't suggest any one particular one, but your immunologist may have an expert that they have reached out to before, that they've shared patients with before. And so I would really recommend just having that open conversation with them and seeing if they can assist you with connecting with a research center in a way where your immunologist is also helping to bridge that gap as the local contact. That's the best way for that to move forward. All of that being said, for anyone who's interested in research or in the field of immunology or any field for that matter, clinicaltrials.gov is a great place to look to see if there are any open clinical trials that could involve your specific condition.
Thank you. All right. We had a question about whole exome sequencing, but we just kind of touched on that. So we're going to move on to the last couple of questions. This individual asks, in adults, can subclass deficiencies be transient, or is IGRT typically for life?
Okay, so um, yes, I think that subclass deficiency can be transient. And if a patient is on replacement for subclass deficiency alone, especially as an adult, yes, I would feel that, of course, I'm not giving direct advice. This has to come through your immunologist who's looking at all the details. And if the scenario is not extremely severe, just from a general perspective, yes, it certainly could be feasible to come off of infusions and reassess. In my experience, um, one potential pitfall is that, say, for example, the defect is still there and the patient continues to manifest infections off of immunoglobulin. If the diagnosis is not an immunologically profound one, in other words, there are not a lot of abnormal labs to go off of, for example, a IgG subclass deficiency in isolation, then sometimes it can be very difficult to then get immunoglobulin approved again through the insurance company. So that is a potential pitfall to keep in mind. But um, for patients who do not have a deeply ingrained or profound or antibody deficiency, who have been doing well on infusions and are interested in coming off and being reassessed, generally I do have that conversation and consider a pause from infusions for reassessment.
Thank you, Dr. Wall. All right, and this is going to be our last question. We are going to revisit something that you mentioned during your talk that I think piqued a lot of people's interest, myself included. And we had a couple folks wondering why you mentioned that IgG subclass deficiencies are controversial. So, of course, we're not getting too crazy over here, but is there anything comfortable that you'd be sharing as to why you might have said that?
Sure. So, a low IgG subclass alone can be detected in the general population, even in people who have never had any issues with infections alone. So therefore, it really makes it hard to hang your hat on subclass deficiency as the only explanation for a susceptibility to infections. Another reason is that the normal cutoffs or the normal reference ranges for IgG subclasses were changed by most commercial labs, really changed substantially several years ago, so that many patients who previously flagged as having a low IgG subclass then no longer their value was now in the normal range. Okay, because that normal reference range became much sort of stricter. Okay, um, and because there is overlap in the roles of the IgG subclasses. So most clinical immunologists believe that even if one subclass is low, that the other subclasses compensate enough or cover enough so that the patient should not be getting sick in a substantial way. All of that being said, I do not commonly check IgG subclasses. I will check them in very limited scenarios. I will check them if the patient has absent IgA to see if there is that that connection with the absent IgA and the low IgG2 subclass. I haven't found that yet in 10 years, but it is in the literature, and I know a lot of centers have a handful of patients with that finding. Sometimes I will also check IgG subclasses in a patient in which they, at every checkup, the pattern of infection really isn't impressive to me. But yet I've turned over every stone and I can't find any answers, and I'm looking for where else can I go with this evaluation? Are there any additional clues that I can find? Sometimes in that scenario, I will check IgG subclasses, but it's rare, even in that scenario. And the way that I use it in my mind at that point is that I think, okay, if there's a low IgG subclass, and especially if I capture that on at more than one point in time, so it really is consistent, might that be one small piece of information that tells me, okay, this is some degree of laboratory evidence that tells me that your antibody compartment is not entirely intact, right? Or is not entirely robust. And the only way that and the way that that translates moving forward to me is to say, okay, well, instead of me just saying, all right, let me just turn you back over to ENT or to pulmonology, right, or to whoever referred you to me, saying, we've turned over every stone and we can't find anything with the immune system. Let me check again in 6 months, right? Let me check the subclasses again, but let me also check the total immunoglobulins. Let me also check your pneumococcal titers again in 6 months, because might this be the very first sign of the development of sort of an unraveling or worsening of the immune system? In 10 years, I've had only one patient with IgG subclass deficiency whom I have started on immunoglobulin replacement. Is the patient that I mentioned just briefly earlier, and that's the one that had absent IgG2. It's the only time that I've ever seen that. The patient on more than one measurement had completely undetectable IgG2, and the immunoglobulin was really life-changing for her.
Wonderful. Well, that was super interesting. Thank you for indulging us all in that last question. Well, that's going to wrap our Q&A for tonight's webinar. Thank you so much, Dr. Wall, for your patient and thorough addressing of everyone's questions. And thank you to our audience for asking such interesting questions. And we are just going to share a couple more things from IDF before we close out for this evening. Dr. Wall, thank you so much for joining us. I know you probably have things you want to get onto about with your day, so feel free to hang around for the last couple minutes, or if you need to sign off, that's perfectly fine too. But thank you so much for joining us this evening.
All right, Emma, you're quite welcome, and I greatly appreciate being invited. And for the audience, I appreciate your attention. And really, the questions were stellar. You brought out a lot of very insightful points with your questions. So thank you so much. Have a good evening, and I'd be happy to come back at some point.
Thank you, Dr. Wall. Take care.
All right.
All right, everyone. Well, thank you so much again for those wonderful questions, as Dr. Wall mentioned. Before we wrap up, I'm just going to quickly share a couple of resources and upcoming events that we have here at IDF. So please be sure to check out our website for additional resources, upcoming events, and more. All IDF materials are free to access, print, or have mailed directly to you. And if your question was not addressed during the program tonight, you can contact our resource navigator through Ask IDF. She will personally connect with you to tackle your question and direct you to appropriate resources. And links to access Ask IDF and the Immune Deficiency Foundation website are being shared in the chat as we speak. You can even take IDF on the road with our engaging podcast series. You can find programs like Bold Conversations and Undiagnosed by searching for the IDF podcast. We also have a brand new young adult podcast that just launched this week called Chronic 20, so definitely check that out. I'm also excited to share about a few of our newest resources, one of which is our immune system self-assessment. It's a 10-minute questionnaire, which you can take to help identify potential signs of PI and also to guide a conversation with your doctor. And again, the link to find that questionnaire is being shared in the chat. Another awesome new resource we have is our Traveling with PI checklist. This is a free to download resource that you can customize before your next trip to keep you organized and healthy as you travel. And again, the link to that is being shared in the chat. Are you looking for ways to connect with others who are navigating life with the PI? You might be interested in joining one of our many Get Connected groups. These groups are free, virtual, and volunteer-led opportunities to connect with others with PI all over the US. We offer location-based groups or nationwide groups, and because these groups are virtual, you can join any group, time, leader, schedule that works for you. IDF's new documentary, Compromised: Life Without Immunity, offers an intimate look into the world of those living with primary immunodeficiencies. Screenings and private watch parties are available now by requesting the film at primaryimmune.org/compromised. And while in-person walk events have wrapped up for the year, it's not too late to join Walk for PI. Visit the website, which we're linking in the chat, to register and build your team for the virtual coast-to-coast option. And in case you don't know, we do offer webinars each month, and we hope to see you at one of our upcoming events. We have 2 more in 2024. Here's a look at what we have coming up later this year. And on that note, if you have a great idea for a topic or a presenter for a future event, we definitely want to hear from you. Visit the link in the chat to submit your idea for consideration. And before we close, we want to again thank our incredible sponsors for supporting our education initiatives here at the Immune Deficiency Foundation. We appreciate everyone's participation this evening, and I want to give a huge thank you again to Dr. Wall for his time and expertise. We hope to see you at our next webinar on November 21st, and I'm going to leave the webinar up just for a couple of moments in case anyone wants to revisit any of the links that we shared in the chat tonight, so please feel free to check those out. Otherwise, take care and have a great evening.